course is a live course, and we will be going over fluid and electrolytes for nursing school. A couple seconds for people to come join in, but we're going to be doing a live course over fluid and electrolytes. So we're going to go over IV fluid types, so the differences between isotonic, hypotonic, and hypertonic fluids, and of course all the fun electrolytes you need to know for nursing school. Now this is pretty big topic for, in general for fundamentals of nursing, but you guys will find out, if you're in nursing school right now, you'll find out that this is a topic that you'll need to know throughout the entire program, because lots and lots of different pathophysiologies fall on understanding these concepts. So truly is a fundamental of nursing school in general. So I'm excited to go over this, and this seems like to be a pretty popular struggle with nursing school. I remember when I was in nursing school. Hi, Kamisha. Thank you for joining in. You're a first-time nursing student. That's exciting. Just to kind of introduce myself a little bit. So I'm a registered nurse, or I'm actually a family nurse practitioner now. I'm primarily in education. I've been in education the last 2 years. But been doing, my own education. I've been doing a lot of CU courses for practicing nurses, and then decided that helping nursing students was my passion. Education has always been one of my favorite things to do, especially in nursing school. So I'm excited to go ahead and try to make these kind of concepts simpler for everybody. But yeah, I've been a nurse for 4 years, and then just recently got my family nurse practitioner, and using this for education. So definitely my passion. So we'll go ahead and start. People will be joining throughout the live here, and of course this is being recorded, so we'll be posting it on our YouTube channel, so you guys can find our videos on our YouTube channel on Coursetta Nursing. So you guys can find us there for any other concepts. We go over EKG interpretation. There's heart failure, COPD, pathophysiology, so all the good concepts you'll need to know. So go ahead and drop in the comments if you guys are on, and give me what is the concept you're struggling with the most. I also want to kind of treat this live lecture as a Q&A as well. So if there's something that you are struggling with as a nursing student right now, go ahead and drop it in the comments, and we can kind of talk about it. I have a large library of study guides that we can kind of go over, kind of sidestep from the fluid and electrolytes if there's something else. But yeah, we'll go ahead and get started. So fluid and electrolytes, basically your community health nursing. Yeah, that is one of those hard ones because it's one of those things that's not very objective. You get a lot. I know what you're talking about. There's the questions that they're super subjective, and it's kind of hard to gauge which one's the correct answer. So those kind of questions, especially with mental health too, it's kind of the same thing, where you get into the class and you can study as much as you want, but there's that concept of just like understanding how to go through the question and kind of get to the right answer. So one thing I do definitely recommend, Kamisha, is going and doing as many practice questions as possible. That's what helped me get through it, because there's only so much to study with community health nursing. It's definitely not like the largest quality, or not the largest amount of like material to study, but it's definitely the questions that you have to get good at, like kind of going through the process of answering it and getting to the right answer through those options. So that's definitely something I will have to do a separate course for that. That'd be a good idea if we do some NCLEX practice style questions on community health nursing. So thank you for dropping that in. So fluid and electrolytes. Yeah, so first of all, knowing your lab values is somewhat important for your exam. Now, most of the time they're going to reference the normal values, especially the NCLEX. Now, nursing schools may not be so nice because, they don't like to be so nice sometimes. It just depends on what program you're in. But the NCLEX most definitely gives you the normal values most of the time, unless it's like a potassium. You definitely want to know your potassium normal range, which is your 3.5 to 5. So knowing those simple electrolytes is always good to know. But fluid and electrolytes, what we're going to go over today is, first off, starting with sodium. So we're going to go sodium, potassium, calcium, phosphorus, and magnesium. And then right after that, we're going to go right into the IV fluids and talk about how the IV fluids work and understanding the difference between all those IV fluids, so the isotonic, the hypotonic, the hypertonic IV fluids. And it's actually a lot simpler than you guys may think. So we're going to get into how we can easily understand those concepts. But first, let's start off with the electrolytes. So electrolytes. First, starting off with sodium. Sodium is by far probably our most prominent electrolyte in our body. It controls water balance. So sodium, like the phrase I love to say is that sodium sucks. And what does sodium suck? It sucks water. So wherever sodium goes, the water flows. There's another mnemonic for you guys that you guys can remember. But sodium is a huge player in water balance. So if you guys understand that, you're going to understand the risk factors, the signs and symptoms. But what is your nursing program going to want you to know about fluid and electrolytes? Well, sodium is definitely one of those. So we want to know the difference between hyponatremia and hypernatremia. So hyponatremia, we're going to start with that. The normal range is 135 to 145. It, once again, plays a crucial role in that fluid balance. Let's first start with the risk factors. So hyponatremia, that means you have a low amount of sodium in your blood. So when you guys hear hyper, it's talking about the normal ranges in your blood, which is important, which we'll get into here in a second. But what are the risk factors? So we have, what causes low sodium in the blood? Well, there's two different reasons for that. One could be dilutional. So think you have table salt sitting in a cup by itself, and then you just dump a bunch of water into it, and now it's diluted, right? The concentration of that sodium is less because now there's more water than there is sodium. So think of it no different. Think of any condition that builds up with water. So, of course, kidney disease. If our kidneys stop working, we're going to start holding on to a lot of water. Same thing with heart failure. If our bodies are not doing very well distributing the blood throughout the body, it then starts seeping into the skin, into the third space tissues, which what we see as peripheral edema. So we got swollen ankles. That is where you would see hyponatremia. So a buildup of fluid in the body that is called your dilutional. So that's a risk factor of low sodium in the blood. And you guys just join in. Go ahead and drop in the comments. If you guys have anything you want to clarify as I go, please feel free to drop in the comments. I'll answer your questions. But we're going to keep going. So yeah, if there's a lot of water, any condition that causes your body to hold on to water, you're at risk for low sodium. Okay, so it's really just don't even complicate. Don't try to remember the conditions one by one. When you guys go through your nursing program, you're going to go over like the simple pathophysiology of all these conditions. So like heart failure, what's the main thing? Well, you're holding on to water. Okay, well, if you're holding on to water, that's the rule, right? If you hold on to water, you're at risk for low sodium. Hey guys, it's Will Kirkpatrick, nursing educator inside Coursera. I wanted to let you guys know that I will help you with anything you need at any time if you just send me a text at 940-218-4062, 940-218-4062. Let's get back to the video. Now, what's the other cause of hyponatremia? It could be just direct loss. So giving diuretics. So heart failure, once again, we give patients with heart failure diuretics, and diuretics, if you don't know, are medications we give to get rid of fluid buildup. So if you give a medication, diuretics, it cause sodium to spill out of the kidneys. The body's not holding on to sodium as much, which is part of the reason why water leaves. If sodium leaves, once again, the phrase I love to use is sodium sucks. So wherever sodium goes, the water is going to follow as well. So if sodium's leaving the body, then water is going to leave the body. So that's kind of how that medication works. So you're at risk. Direct loss of sodium is another reason for hyponatremia. Now, diarrhea and vomiting is also another risk factor. Not as common. It's more associated with potassium, but it is, you can have hyponatremia. And then, we sweat. If you're someone who's profusely sweating, it's also not a very common one, but it is a possibility. So diaphoresis is another reason you could have low sodium in your blood. Let's talk about signs and symptoms. And kind of like, if you guys understand the function of sodium, then you're most likely going to understand the signs and symptoms. So one thing that you could remember, it's quite a bit to remember, honestly, but it does kind of help organize it, is remembering salt loss. So once again, hyponatremia means what? Low sodium. So if you remember salt loss that's associated with those signs and symptoms, then it might help a little bit. But there's quite a bit to remember here, I'm not going to lie. But if you remember, what is the function of sodium? Once again, it's water balance. So when you have a low amount of sodium, water's not really being influenced by anything, right? So it's going to sit. So think of like water sitting, your salt loss here. So anything where just water, if there's a whole lot of water, what's the problem? Well, you're going to have problems such as these little salt losses here. So seizures. That's a very common concept on the NCLEX and your nursing exams. So if you have a patient scenario question where it's a 45-year-old male with hyponatremia and they have altered mental status, that's a huge one. What is one of the one of the biggest risk factors for this patient? Well, one of the biggest risk factors is that they could have seizures because fluid possibly is sitting in those cerebral cells and it's causing irritation in the brain, which could cause irregular electrical activity in the brain, which is what? A seizure. So that is a sign and symptom. Abdominal nausea and vomiting. So part of that's because if you have fluid retention, it could cause something called ascites. So fluid retention would like to sit in your belly. That's another spot that the fluid likes to seep into, like third spacing. So if you have that, you have a bunch of weight sitting on your stomach, it naturally causes nausea and vomiting. Lethargy and confusion. So once again, the body does not, the brain itself loves sodium, and when it's low in sodium, it freaks out. Okay, sodium's super important for water balance everywhere, and especially the brain. The brain is super demanding, of course. So when you don't have enough sodium, there's not enough energy technically with the brain, and you're going to have altered mental status. The things aren't clicking inside there. So seizures and confusion are a sign and symptom. Then tendon reflex is diminished. So this is a not as common sign and symptom that you'll see, but it is a possibility. It's more really associated with like a potassium or a calcium, which we'll get into. But you can have this with, hyponatremia as well. Limp muscles, orthostatic hypotension. So this is another thing. So orthostatic hypotension is associated with blood pressure. So anytime you have, fluid status changes such as fluid overload or fluid deficit, so dehydration, then you're going to be at risk for orthostatic hypotension. Stupor and coma, once again, the biggest thing that the nursing exams will ask about, usually what they like to correlate signs and symptoms of hyponatremia, usually something with the brain. Like I said, the brain does not like low sodium. So look, seizures, confusion, stupor/coma. So stupor is like your very altered mental status, and in coma, of course, non-responsive. So that's a very common thing that they'll put on your nursing exams and kind of test your ability to identify that. And then stomach cramping and spasms is another thing, not as commonly questioned about. All right, so moving on down to the management, we're going to stick on hyponatremia, and then we'll move right to hypernatremia. So management, so we talked about the risk factors, dilutional versus direct loss. Dilutional, anything that likes to hold on to water, you're at risk for low sodium. So let's first start with that. Okay, well, there's too much fluid, so we need to remove it. That's the management. It's as simple as that. Don't try to overcomplicate it. What's the cause? Well, let's treat the cause. Okay, well, what do we give to get rid of fluid, guys? It's diuretics. So diuretics, and then a lot of times you'll see fluid restriction as well, because why? Well, if we have a condition that's causing our bodies to hold on to fluid, well, we want to try to restrict the introduction of more fluid that could be third spaced into the body and causing more and more issues. So we're trying to increase the output versus the intake. So that way we can, get our bodies back to our normal water balance. All right. And then direct loss. So if you have a direct loss, such as, too much diuretics, diarrhea and vomiting, less likely diaphoresis, then there is sometimes they will give hypertonic IV fluids. Now, if you guys weren't here earlier, we are going to go over your hypotonic, isotonic, and hypotonic IV fluids at the end of this course. So first starting talk with, of course, we're introducing hypertonic IV fluids here. 3% saline is your most common. We'll go into the details later. But why are we giving hypertonic fluid? Because hypertonic IV fluids, guys, are high in sodium. Okay, so high amount of sodium, well, simple as that. Well, if we have a low sodium, let's replace it with a high amount of sodium fluid. So we're just going to give some hypertonic IV fluids. But the biggest thing they love to question about is that if there is a nursing scenario in your nursing exam that says, okay, you have a patient with hyponatremia, their sodium level is 120, and the nurse is preparing hypertonic IV fluids. Which of the following nursing complications should the nurse look out for? That's a good example of what they would ask for. Well, you want to really pay attention to giving hypertonic fluids. You really want to carefully monitor the sodium levels. That's a pretty common concept they love to ask about. So make sure you guys know that hypertonic IV fluids, you really have to watch the sodium levels, because if you improve that sodium too fast, you're very well increasing their chance of having brain damage that way, because the fluid will shift too fast. And then, like I said, with hyponatremia, the fluid likes to sit in the brain cells. Well, when you put hypertonic fluid, we're going to talk about this later with the IV fluids, but now the sodium concentration's high in the vascular space. So osmosis, the water flows and follows that sodium out of the brain cell, and now the brain cell's like, oh, I have no water left. So then that causes, some pretty big significant issues with the brain. It can cause even worse cerebral edema than they already had. And then, of course, seizures and possibly death there. So that's something you definitely want to know about for your nursing exams, is that anything that talks about hypertonic IV fluids, priority is watching the mental status of the patient and monitoring the sodium levels frequently. And then, of course, direct loss, we encourage high salt foods to replace the low sodium as well. So your nursing interventions, always, since sodium is very high into controlling water balance, daily weights, and strict intake and output, that's always a thing. Monitor level of consciousness. Once again, guys, the brain does not like low sodium, so remember that. Monitor level of consciousness. That's typically the most commonly thing reflected on a nursing question. They'll ask about it. Well, what if a patient is, here's a little test for you guys, and see if you guys can drop it in the comments. What if a patient is altered mental status? What is at risk? Go ahead and drop it in the comments. We'll come back to it. What is your priority when a patient has altered mental status? Okay, if you guys remember your ABCs, what's at risk when you have altered mental status? Go ahead and drop in the comments if you guys know, or just guess, of course. And like we said earlier, if you have a hypertonic fluid, make sure you guys know that. It's this fancy little word called central pontine myelinolysis. That's the fancy word for severe cerebral edema that can cause permanent brain damage. So go ahead and drop in the comments, guys. If you guys know, we'll go back to it about what happens when you have altered mental status. What is that technically saying? Because, prioritization questions, you're going to see it a lot in nursing school. Prioritization questions, of course, they're going to test your ability to identify what's the most acute issue going on, depending on the patients that you have in the scenario. And I'll let you guys answer first, and then we can get into it. I'll go over hypernatremia first. So, okay, we talked about low sodium. Let's talk about high sodium. So high sodium is above, the normal range, once again, 135 to 145, and high sodium above 145. So what are your risk factors? Well, fluid deficit. So the exact opposite, of course, of hyponatremia. Not rocket science here, but if there is a fluid deficit, there's not enough fluid being introduced into the body, then the sodium concentration will build up and cause hypernatremia. So water and sodium are always being a balance, guys. So it's, it's either one or the other. If they're imbalanced, there's something going on with either the water or the sodium itself. Well, the water, it could be high or low. So if it's low, then we could be at risk for hypernatremia. So conditions such as diabetes insipidus, you're losing lots and lots of water with that condition. Once again, diuretics. Inadequate water intake. So what community is at risk for inadequate water intake? Not community, but patient population. It's your geriatric population. Why? Because they have reduced thirst. So those geriatric patients, they have reduced thirst and they're less likely to take in water, so they're more at risk for hypernatremia. Also, you could, like 99.9% of Americans who have too high of a sodium intake. This is also another risk factor. And then, once again, hypertonic fluids. Really have to pay attention to hypertonic fluids and monitor the sodium very frequently. All right, guys. So not anybody yet in the comments, we'll get back to it. But signs and symptoms. So once again, if we know the function of sodium, it controls water balance. So signs and symptoms, if you remember high salt, so of course, hypernatremia, high salt. Your signs and symptoms will include hyperthermia, increased fluid retention, greatly increased urine output, hypertension, skin flushed and dry. So this right here, skin flushed and dry mucous membranes, is the number one concept they love to ask about on your nursing exams. So a sign and symptom is like a dry and sticky tongue. That's a very common thing they'll put in the nursing scenario question. So you have a patient, 45-year-old male, who is dry and sticky tongue. They have this and that. What is likely the cause of that finding? And it would be hypernatremia. Agitation, low-grade fever, and thirst. So those are your typical signs and symptoms. But once again, guys, if you remember that it causes dry mucous membranes, then you're probably golden with the hypernatremia. And then management, fluid deficit versus excess intake of sodium. So, of course, we treat the underlying cause. So if they have a fluid deficit, not very complicated, not rocket science. Let's just give them more fluids. IV fluids if it's super severe. So most of the time in the hospital setting, of course, we're going to give IV fluids for them. And then excess intake of sodium, well, we want to lower that. So we want a low sodium diet. And then diuretics to excrete the sodium as well. So we just got to watch the fluid balance as well with that. And then once again, anytime we're talking about sodium, always nursing intervention. Let's monitor that daily weight and strict intake and output. And we want to monitor those hemodynamics, and we want to control the hypertension. So that's one of the complications that can happen out of it, is a hypertensive crisis. So because if there's a high amount of sodium in the vascular space, well, that's going to bring the water we do have left in our bodies and expand that vascular space and cause high blood pressure. So that's a reason for that. All right, so if you guys, nobody commented, but we're going to go ahead and go back to where we talked about prioritization type questions. So if you have any nursing scenario, this is a very kind of like a trick that Intulect loves to test people out on. Any nursing scenario that says that, say if you have you see this all the time. You're coming in on your shift and you have 4 patients. You have this patient with this patient with that, and this patient with this. Which patient do you see first? So those typical prioritization questions. Well, if you have a patient with altered mental status, so like someone who's like on the borderline stupor, they like to use the word stupor, coma, or lethargic. If altered mental status is part of your patient finding, that is the priority. Why? Well, it's just another way of them saying that the airway is compromised. So what's prioritization? What's the best thing to remember? ABCs. Airway is your most important. Why? Because that is the fastest way your patient could possibly pass away. B, breathing. Next thing that could possibly make them pass away. And then C, circulation. So if you have a answer option that says patient with altered mental status, unresponsive, that's another way of saying that the airway is compromised. Because if you're altered mental status and, on borderline, coma, then you're not protecting your airway. So that is a very common concept that you'll get asked about on prioritization type questions. So that's just another little side note for you guys. All right, let's move on to potassium. Potassium is so popular. It's a very popular thing that they love to ask about on the NCLEX and, of course, your nursing exams. So if you guys are getting ready to take your fluid and electrolytes test, usually it's in your fundamentals of nursing class, but you guys will find out you're going to need to know this throughout the entire program because it's such a huge concept that gets reflected on constantly. So let's talk about potassium. So potassium helps in nerve conduction and muscle contraction, and it is a huge player in cardiac repolarization. What does repolarization mean? Repolarization just means relax. So re starts with RE. Repolarization equals relax. So helps control cardiac relaxation, in other words. So it's just a fancy word for relaxation. Potassium is a intracellular fluid, so opposite of sodium, which is the extracellular fluid. Potassium likes to stay inside the cell unless something happens to the body where it has to compensate, but its home is inside the cell. Okay, so normal value that this is probably the one, if there is one normal value that you'll need to remember, it is probably potassium, like we talked about earlier. A lot of times the NCLEX likes to bring in, or they typically bring in the normal range anyways. But it doesn't hurt to know your normal values. But if there is one that you had to remember, it's probably potassium. So let's go over hypokalemia first. So we know potassium helps with nerve conduction, muscle contraction, and cardiac relaxation. And it likes to stay inside the cell. That's its home. All right, so what are the risk factors of low potassium? So hypokalemia. Your risk factors are, number one, they love to ask about this, diuretic use. So write that down. Vomiting and diarrhea. You lose lots and lots of potassium if you have a patient who is vomiting a lot or a patient who has nasogastric suction coming out of their stomach. So anytime you lose stomach contents, you're losing lots of potassium. Anytime you're losing lots of water through the bowel, diarrhea, then you're at risk for hypokalemia as well. Inadequate dietary intake, which, not very many people actually do have a good intake of potassium in general. And excessive sweating, which is most likely not going to be asked about in your exam. And then kidney disorders. So anytime you have fluid dilution, there's a possibility of hypokalemia as well, which is another one that's not commonly questioned about. So what is commonly questioned about? Diuretic use. That's going to be used quite often. And then vomiting and diarrhea. You're going to definitely need to know those. That's a pretty common concept you'll see on your nursing exams and the NCLEX. Okay, so what happens when we have a low amount of potassium in the body? Well, we have, number one, they love to ask about it, is it has to reflect to the heart, right? Because potassium, even like clinically, we really do pay attention to the potassium. That's one of our main priorities. First thing in the morning, especially if you're, day shift nurse, is that potassium, you want to look at that. You want to replace it as fast as possible if it's low. Because why? Well, because potassium, anytime it's off balance, then you're at risk for cardiac arrhythmias. Hypokalemia, so think low. So low ST and a low T wave. So you guys see that little circle highlighted there? It is a inverted T wave. So you'll have either a low, like a shallow T wave, or an inverted T wave. So think hypokalemia means low, right? So think low T wave on the EKG. And we go right over, might as well mention it just to compare it and make it kind of more simple for you guys. Hyperkalemia means high, right? Well, if there's a high amount of potassium in the blood, then you're most likely going to be it's most likely related to a tall or, peaked T wave is like the term they like to use on the nursing exams. So it's exactly like I like to say this, the potassium tells you the truth. So if you think potassium, if it's low, you're not going to have a lot of nerve conduction. You're not going to have a lot of muscle contraction. And the heart's not going to be able to relax if you're low in potassium. So arrhythmias are common in both abnormalities, but of course, just know the difference that hypokalemia, low ST / T wave, and hyperkalemia, so high, is a high peaked T wave on the EKG. So just know those differences because they love to ask about that. So low potassium can also have anxiety, lethargy, confusion. Those are also some common signs and symptoms. Paresthesia, because your nerves are irritated. There's not enough potassium to help them relax. And then hypoactive bowel sounds. This is a common one too. What happens if you have hypoactive bowel sounds? What's a complication of hypoactive bowel sounds? You guys would need to know this because they would love to ask about this too. Hypoactive bowel sounds, if your bowels are not moving good, what are you at risk for? Go ahead and drop in the comments, guys, what you think you're at risk for with hypoactive bowel sounds. So that's one thing that they love to kind of reflect on potassium too. So it's the heart, and they love asking about the hypoactive bowel sounds. And then go ahead and drop in the comments. We'll go ahead and go back to that. Let's go over the management while you're working on that. So management, we want to replace the potassium. It's not complicated. Let's not make it complicated, guys. Potassium, if it's low, well, let's replace it. Now, of course, there's some certain concepts, and I remember when I was in nursing school, my instructor basically yelled this out loud, the very first thing. Don't ever give potassium IV push. That is not a thing, and it never will be a thing. So don't ever do it, and if there's an answer option with that, just don't even look at it. So don't ever give potassium IV push. That's something you'll need to know, of course. And of course, clinically, you just never want to give that. Why? Well, if you might ask why, because if you do give it and you change the potassium levels so abruptly in the blood, you're going to likely cause an arrhythmia, and a fatal arrhythmia that can't be reversed. So that's something you just never want to do. You want to give potassium slow per your hospital policy. So a lot of the times it's 50 mLs per hour. If you're currently a nurse, do not hold me on that. But, just from my experience, 50 mLs per hour. And if it's a central line, sometimes up to 100 mLs per hour. So that's a thing. But yeah, just give it slow. Don't ever draw it up and give it IV push. But don't make it complicated, guys. The management is as simple as just replacing the potassium. And then, of course, monitoring for the adverse things, such as the EKG. You want to monitor the EKG rhythm. And then you want to monitor, hypoactive bowel sounds. So I did see someone did put paralytic ileus, and yes, you are correct. So that is the exact thing you'll need to understand. For low potassium, they like to reflect that quite a bit on the NCLEX and your nursing exams. All right, so you may or may not need to know this, especially for your renal exam and med-surg class. You're going to need to know some diet kind of things, especially with potassium, because we're going to get over to hyperkalemia in a second. But when you have renal failure, your kidneys can't get rid of potassium. So you need to have a low potassium diet. So you need to know what kind of foods are high in potassium. But in this case, this is hypokalemia, so you want to encourage high potassium foods. And what are those? Like NCLEX loves to say avocado. They love to say potatoes. They rarely mention bananas, but that is something, of course, we all know about. And then beans is another one they like to put on there. So if the potassium is severely low, then we prefer the IV route. Most of the time, if it's just on the brink, like a 3.3, just depends on your hospital policy, then they will prefer the oral route. So it just depends. But yeah, just remember, guys, don't ever give it IV push. All right, let's move on to hyperkalemia. And like I said, guys, if you guys have any clarification questions, please drop them in the comments. I will answer anything you guys need. This is a Q&A as well. So if there's something that you're not quite understanding, I'll go ahead and answer it for you. If you guys are just now joining, we are going to get into IV fluids too. So we're going over all your electrolytes. So we're going over sodium, potassium, magnesium, calcium, phosphorus. And then we're going to go over the IV fluids and talk about the isotonic, hypotonic, hypertonic. So go ahead and drop in the comments anything you guys are wondering about with this concept, and we will help you out. So, all right, hyperkalemia. Hyperkalemia greater than 5. So what are the risk factors? So like I said earlier, the biggest one they like to reflect on is kidney failure. So anytime you have a kidney dysfunction or failure, you're at risk for holding on potassium. So certain medications that can cause this as well, they love to ask about this too, guys, is ACE inhibitors. So you need to know that is a risk factor for hyperkalemia. Potassium sparing diuretics as well. Even though that's the whole point of the medication, they do like to ask you if that's one of the adverse effects. Of course, since it's preventing potassium to be spilled, it could potentially cause hyperkalemia, which is not necessarily a common thing in real life, but that is a common question they like to ask in the NCLEX and nursing exams. So they just want you to know, they just want to make sure you guys know the adverse effects of those medications. So there is some pharmacology concepts related to hyperkalemia too. And then acidosis, we can get really dive deep into the pathophysiology of that if we want, but that's a whole nother course. But if you guys really want me to, go ahead and drop in the comments. We can get into it. Dehydration and trauma or burns. That's another thing that could be another whole course too, talking about how potassium flows throughout the body. But if you guys just know simply that these risk factors, anytime there's damage to the cell, if you guys remember, intracellular fluid is the home of potassium. Well, if there's damage to that cell, well, the potassium has to go somewhere. It's going to leave, right? It's going to go in the vascular space. Well, vascular space that's high in potassium is called hyperkalemia. So there is the rationale real quickly for trauma or burns because it damages your cells. Signs and symptoms. So we talked about this. Number one thing they love to ask about, since potassium is very sensitive to the heart, is they're going to ask if you understand that tall T waves are related to high potassium. So that's a thing. Definitely write that down. Now, hyperkalemia is more likely to cause widened QRS complexes. If you guys know, I'm not sure how far you guys are on your nursing program or not. We can get into it a little bit if you want. QRS complex is that giant, I think, you guys can see my mouse. So this complex right here. So QRS. So if this is widened, so greater than those 3 small boxes, that is a sign and symptom of hyperkalemia. It could potentially be caused by hyperkalemia. If you guys remember that hyperkalemia is a big deal with cardiac repolarization, other words, relaxation. So when there's too much, then your heart is too relaxed. So that means it's going to take longer. It's going to be slower. So that's your widened QRS complex. And that, if you have a widened QRS complex, if you guys don't know, that's automatically a ventricular arrhythmia, which is pretty serious. You're not getting the correct circulation throughout the body. muscle cramps, and then hyperreflexia is another thing that they like to ask about. So once again, guys, nerve conduction and muscle contraction. That is a common, exactly what I talked about earlier. Potassium tells you the truth. And then hyperactive bowel sounds. So just the exact opposite of hypokalemia, where hypoactive bowel sounds, what's the risk factor once again? Paralytic ileus. Well, with hyperactive bowel sounds, it's the exact opposite because you have too much potassium. So there's that. And then management, once again, it's not complicated, so don't overcomplicate it. If you have too much potassium, then we want to get rid of the potassium. Now, the causes kind of depend on your route of that. So, of course, if it's a patient with renal failure, then you're most likely, giving them dialysis, which helps get rid of the potassium artificially there. And, of course, you want to reduce potassium intake. So knowing your avocados, potatoes, bananas, and beans are your high potassium foods. And then in severe cases, so say like K-Exolate. I don't know if you guys are familiar with K-Exolate or not, but K-Exolate is a very common medication they like to give to help get rid of the potassium. And that's usually through the bowel. So you're going to get, diarrhea with that, which is, of course, if you guys remember, look at there, is diarrhea is a common risk factor for hypokalemia. So it gets rid of the potassium through that route. But K-Exolate is very common. But if you don't, there has been times, and me clinically also, that we will give calcium to reverse the potassium. And a lot of times calcium is given with insulin and glucose as well to ensure that it is a safe transition of hyperkalemia. So that's another possible way of lowering the potassium. So if you guys have any questions further about potassium, go ahead and drop in the comments, but we're going to move on to calcium. All right, so calcium. This is the signs and symptoms are pretty commonly questioned about. So if you guys remember the signs and symptoms of hypo versus hypercalcemia, then you guys are going to be pretty golden. So normal range for calcium is 9 to 11. The primary function is helping with nerve transmission. So muscle function. So without nerve transmission, you can't have muscle function, right? So that's where the signs and symptoms get kind of reflected, and they love to ask about on the NCLEX and the nursing exams. Let's first start with hypokalemia or hypocalcemia. Your risk factors is vitamin D deficiency. Well, why? Because vitamin D helps synthesize calcium. Well, if you don't have enough vitamin D, then the calcium's not going to be used adequately, and it could be spilled by the kidneys. And if that happens, then you lose your calcium. So also hypoparathyroidism. So if you guys may or may not know right now in your program, the parathyroid controls calcium and phosphorus balance. So it's directly related. So if there's a low parathyroid, then you have a low calcium. If it's high parathyroid, then you have a high calcium. And then kidney failure. So kind of the exact opposite of potassium. Kidney failure is a risk factor for hypocalcemia versus a risk factor for hyperkalemia. And then inadequate dietary intake, so nothing too common with that. And then certain medications such as loop diuretics can also cause hypocalcemia because it helps spill calcium as well. All right, so signs and symptoms, this is something you'll definitely need to know. So muscle cramps and spasms, of course, probably the most common thing, but this is what the NCLEX loves to ask about. You need to know Schaafstex and Trisell's sign. Like, you 100% will need to know it. Whether they do or may not ask in the nursing program, they most likely will. But the NCLEX, that's like almost guaranteed you're going to get something along the lines of the Schaafstex and Trisell's. So what is Schaafstex? What is Trisell's? Well, and what is it even related to? Well, if you guys remember, if we have a low amount of calcium, just think, our nerves are super irritated. They don't have enough calcium to even transmit and complete a muscle contraction. Okay, well, if there's think of it like a sound wave that keeps getting interrupted, right? If a sound wave that's getting interrupted, or think of it like a Wi-Fi connection where it's like lagging. Okay, well, if you have a low or pretty terrible Wi-Fi connection and it's lagging, well, same thing with calcium. If you have a low amount of calcium, it's lagging that transmission to that communication to cause a muscle contraction. So you're going to have nerve irritation. All right, so that's what stems and causes Schaafstex and Trisell's. Shavstex, think it starts with a C, right? Shavstex is a facial twitching of the facial nerve. So it is a cranial nerve. Okay? Shavstex starts with a C. Think C also, cranial. So it also starts with a C. So that's how you can know the difference and remember the difference if Trissals is which one or Shavstex is which one. Well, Shavstex has to deal with your facial twitching when you tap it. So when you actually tap the facial nerve on their face, you're going to see some very hyper reflexed reaction to that tapping. So that's what Shavstex sign is. And then Trissal sign. So this is when you put a blood pressure cuff on, for example, and you increase the pressure on the upper arm. And then you're going to see wrist flexion. So this is like uncontrollable wrist flexion because there's nerve irritation, right? That is caused by the pressure and decreasing even more of the communication to that, and it's going to cause rigidness. So that's another sign that they love to ask about. So tetany, that's your, rigidness. Saying if it's all kind of clustered together. There's nerve irritation, the muscles are super irritated, so you're going to have hyperreflexia, numbness and tingling, and everything's just irritated because there's not enough calcium. And then seizures, once again, as well. Your brain also gets irritated. And then calcium, it does have to do with helping the heart actually contract. So it's cardiac depolarization, so cardiac contraction, versus where we talked about potassium helps with cardiac relaxation, in other words, cardiac repolarization. Well, calcium is the opposite. It helps the heart, sufficiently contract just like everything else. Well, if you guys know, the heart is a muscle, right? So just like everything else, where calcium's helping your muscles contract, well, it's the same thing for your heart. So just know, anytime you're low in calcium, you're going to have a hard time completing a contraction. So arrhythmias would not be surprising with hypocalcemia. Okay? And then, of course, guys, once again, ask me any questions if you guys need anything clarified. There's lots and lots of details we could dive into if you're really wanting to understand the deep details of stuff. But to not make this live go for hours and hours and hours, we're going to try to go over it, just what you need to know for your nursing exam and the NCLEX. All right, so management, if you have a low amount of calcium, let's not complicate it, let's replace it. All right, so calcium supplementation. And then we talked about how vitamin D plays a role in calcium synthesis, so it's the absorption of calcium or the use of calcium in the blood. So if you're low in vitamin D, you could be low in calcium as well, so it would make sense to supplement vitamin D as well. And then treat the underlying cause. So if you have a parathyroid disorder, which is obviously not very common, then you would want to treat that. And then seizure precautions. Now, you guys will want to write this down. They like to ask about this. If you have a low amount of calcium in the blood, you're at risk for seizures, right? So one of the interventions they may or may not ask about in your nursing exams is that one of those interventions is that you need to implement the patient on seizure precautions if they have a low calcium. So your seizure precautions, guys, oxygen and suction at the bedside. There's padding on those side rails for protection. The side rails are up at all times. They're in a low bed. And of course, if they're outside of the hospital, when it's supervised during, physical activities, especially swimming, and they should wear a medical alert bracelet. So those are your common things that will kind of reflect on your nursing exams. So, all right, let's go to hypercalcemia. So anything above 11 is considered your hypocalcemia. All right, so what are the risk factors? It's the exact opposite, of course, of hypocalcemia. You have a high amount of parathyroid, so parathyroid is directly related to the calcium level as it controls that and the phosphorus balance. Cancer, so why cancer? Well, especially involving bone cancer. So, of course, calcium likes to sit in the bones. That's part of its home there. So if you have bone cancer, it degenerates and then it gets released into the blood. You're going to have possibly a hypercalcemia. Excessive intake of calcium and vitamin D supplements. Then prolonged immobilization. Why? Well, if you think, immobilization causes what? Bone degeneration. So same concept there. So when bone degenerates, it goes and leaks the calcium into the blood. Well, if there's a lot of calcium in the blood, it causes hypercalcemia. And then medications such as thiazide diuretics is another one that could be possibly put on your nursing exams, but that one's definitely not common. All right, so signs and symptoms. So it's the exact opposite of hypocalcemia. Now, I will say, guys, hypocalcemia is extremely common. Hypercalcemia is not as common, but if you guys just remember, this is where I like to tell my students a lot of the times. Hey guys, it's Will Kirkpatrick, nursing educator inside Coursera. I wanted to let you guys know that I will help you with anything you need at any time if you just send me a text at 940-218-4062, 940-218-4062. Let's get back to the video. Is not so much focus on remembering everything, but if you can remember one thing and just know that very well, and actually just know, like, if it's outside of that, then it's not this. So I know that kind of sounds confusing when I say that, but if you know hypocalcemia really well, then, like, say for example, fatigue and weakness or hyporeflexia, right? You know that does not belong in hypocalcemia, because hypocalcemia is hyperreflexia. We're super irritated. Our muscles are irritated. Well, if you guys just think the opposite, especially with these kind of electrolytes, they're always opposite of each other, of course. If you just really know hypocalcemia really well, you're going to know hypercalcemia really well. Okay? So excessive thirst and urination is a sign and symptom. Confusion and cognitive changes, that's a pretty common one that they like to ask about as well. And then here we go, bingo, kidney stones. They love asking about this. If you have hypercalcemia, so high amount of calcium in your blood, you're at higher risk for calcium deposits to form, crystals to form in the kidneys, and cause something called kidney stones or renal calculi. So that's another term they may use in your nursing exams and the NCLEX, but just know that's one of the signs and symptoms / risk factors or complications of hypercalcemia. And then management, so fluid hydration to promote urinary calcium excretion, diuretics to increase that as well, biphosphonates to inhibit bone resorption. So we talked about how bone degeneration is a risk factor for hypercalcemia. Well, if that's the cause of it, then we want to give biphosphonates to prevent that from happening. And of course, parathyroid, that's a very rare thing that causes it. But it definitely, if there is an issue with if there is an issue with the parathyroid, then you're going to have an issue with calcium. So that's a pretty much guarantee right there. So surgical is not out of the question there if it's a parathyroid issue. All right, guys, so we're getting there. We're almost to the IV fluids. So if you guys are struggling with hypotonic, hypertonic, or isotonic IV fluids, we'll get into that here pretty soon. We're on the last two electrolytes. So we're going to go over magnesium now. Now, magnesium is super easy. I just want you guys to remember one thing. Magnesium is super relaxing. It's basically, think of it no different than a sedative medication. It's not obviously as powerful as a sedative medication like a Xanax or a Ativan or a what's another one? I can't think of it right now. I'm trying to think of the trade name. Midazolam, Versed. Those are your anxiolytic medications. Not as severe as that, but it is. If you think of it like a sedative medication, this is all going to make sense to you. All right, so what is magnesium? Also helps with muscle and nerve function, bone health, energy production. But if you remember, it has a major relaxation effect. This is all going to make sense. So your normal magnesium levels is 1.5 to 2.5. So your risk factors, so of course, if you don't eat a lot of magnesium, you could be low in magnesium, or malabsorption and diarrhea. Alcoholism is another one they like to question about. Kidney disorders and diabetes. And then your medications that could also, not as commonly, but could, diuretics and proton pump inhibitors too. Signs and symptoms. Now, risk factors, guys, it doesn't really get questioned a lot with these kind of concepts now. But what they're going to ask you about is definitely the signs and symptoms. And you need to know that magnesium is super relaxing. So if you have a lot of magnesium, it's relaxing. If you don't have a lot of magnesium, you're not relaxed at all. So hypomagnesemia, low magnesium, you don't have any relaxation in your body. So what happens when you're not relaxed? Well, you're anxious, right? So think of it. Just think of a patient who's super anxious. What's going to happen? What are you going to see on the vital signs monitor? Well, you're going to see heart rate, blood pressure, and respiratory rate go up. You're going to have muscle cramps and spasms, just like your calcium and potassium deficiencies. Hyperreflexia. This is one you need to remember. So not a lot of relaxation, right? Well, you're going to be super rigid, and the reflexes are going to be super fast. You're going to have tremors and twitching. Just think of it as a super anxious patient there, and that is your hypomagnesemia. You're going to be super weak. You're going to have irregular heart rhythms as well, because magnesium, if that's out of whack, then you have a risk of EKG changes as well. Now, what's one thing? Let's see if you guys see if you guys know this. Let's question you guys out. What EKG rhythm? It's a lethal EKG rhythm. Just to give you a hint, which one causes, or what EKG rhythm is related to hypomagnesemia? So a low magnesium level. Go ahead and put it in the comments there if you guys know it. But what lethal rhythm is associated with low magnesium? Go ahead and put it in the comments and see if you guys know it. It's a little side concept there. All right, so if you guys remember, it's not a lot of relaxation going on, right? So just think of it as an anxious patient. That is your signs and symptoms. Management, not complicated. Let's replace the magnesium if it's low. Okay, well, if they're super unrelaxed, right? What are they at risk for? Once again, seizure precautions. And you want to, of course, increase the magnesium intake too, if that's appropriate. All right. So see if you guys drop it in the comments once again. If you have a low magnesium level, what lethal heart rhythm is associated with that, with a low magnesium? See if you guys know that. All right. So hypermagnesemia, so level above 2.5. So risk factors with that. Number one, they will ask about this. Kidney failure. When you have kidney failure, magnesium gets retained. And we're going to talk about what that means here in a second. So excessive intake of magnesium as well. Antacids are a possibility. Adrenal insufficiencies, diabetic ketoacidosis. But number one, guys, you need to remember is kidney failure. That is your most common risk factor for hypermagnesemia. Now, hypermagnesemia is not a very common thing clinically. I've only had one patient ever with a hypermagnesium level, and it is crazy how much of a difference it actually makes. When I say like magnesium is relaxing, it is relaxing. So I had a patient that was, this was years and years ago now, not like that long ago. I've only been a nurse for 4 years. I had a patient and I've read about it, but I didn't think that the patient's heart rate was super, super low, right? And their blood pressure was super low, and they were altered mental status. But then, I was going through the labs, just getting in for my shift, and I looked and I was like, holy crap. This is the first time I've ever seen a magnesium level that was actually high, because typically it's low, right? But this is the first time I've ever seen it high, and it was crazy how big of a difference it makes on a patient's vital signs. Their heart rate was super low. They were having issues, but it was crazy to see. So if you guys remember, magnesium, once again, is extremely relaxing. Think of it like a sedative medication, basically. You're going to have bradycardia, so heart rate below 60. You're going to have hypotension because they're way too relaxed. And number one, guys, write this down, is that they are going to have respiratory depression. And what does that mean? Well, if you have a patient with high magnesium, what's your priority? ABCs, airway. Okay, if they have altered mental status, that's another way of saying that they have a compromised airway. And respiratory depression, so a respiratory rate below 12, and they have decreased ventilation, they're at risk for respiratory compromise. So that's something they'll definitely like to ask about with the magnesium on the NCLEX and your nursing exam. So remember to write that down as well. And once again, if they're super relaxed, well, their bowels are also going to be slow. So hypoactive bowel sounds is another thing. And of course, weakness and lethargy too. All right. So management. I see nobody in the comments yet has put anything in. What do you guys think? We'll just mention it real quick. We're going to keep moving on. What rhythm is actually associated with hypomagnesemia? Go ahead and drop it in the comments and see if you guys know it. It's a lethal rhythm, just to give you a hint. But what rhythm is associated with low magnesium? All right, so moving on, management. So if we have a high magnesium level, so of course we're going to lower the intake of it. So calcium administration is not uncommon. It helps reverse and lower the magnesium levels. Diuretics, because once again, kidney failure is one of your biggest risk factors for hypermagnesemia. So you want to reverse, get rid of that by excreting it through the urine. And then, of course, restrict magnesium laxatives as that can increase. And, of course, antacids, there's another possible one as well. And then, of course, if it is renal failure is the cause, then you want to do hemodialysis. Then calcium gluconate is the antidote for a magnesium overdose. So that will help reverse the magnesium levels. So nobody dropped it in the comments, but just to kind of answer the question, a low magnesium level is associated with torsades de pointes. So if you guys don't know, torsades de pointes is related to a prolonged QT interval, which QT interval is like your relaxation time of your heart. So when that's prolonged, well, the heart gets a little too messed. The QT interval gets a little too long, and then it causes a ventricular arrhythmia called torsades de pointes. And the treatment for that is magnesium infusion. So that would be your answer for that. All right, last electrolyte here. This one's the least commonly questioned about one on the fluid and electrolytes exams and the NCLEX, but it is there, and it's usually reflected on like a renal failure patient. But phosphorus, so a normal phosphorus level is 3 to 4.5. So a low hypophosphatemia versus hyperphosphatemia. If you guys remember that this is directly related inversely to calcium. So we talked about the parathyroid hormone, right? Well, parathyroid hormone is directly related to the balance of calcium and phosphorus. So it's really, if you literally, I might even actually skip over this just to get right to IV fluids. If you think hypocalcemia, it is the exact same thing as hyperphosphatemia because they're inversely related. And then hypophosphatemia is directly related to hypercalcemia. So if you guys see, remember hypocalcemia? Remember here, signs of hypocalcemia, they love to ask about this. Schaaf's text, intrasalcine, because there's not enough calcium. There's lag in the communication nerve conduction to the muscles, so it's super irritated, right? So Schaaf's text is that facial tapping, twitching when you tap the cranial nerve. So C starts with C, cranial nerve. And then Schaaf's text also starts with a C, so that's how you can remember that. Then intrasalcine, when you inflate the blood pressure cuff, causes involuntary wrist flexion there, because the nerves are super irritated. So literally think of phosphorus as a direct inverse relationship to calcium. So, and of course, if you're in like med surg right now, oh yeah, I see a comment there. Oops, it should be torsades de pointes. Yeah. So you're right. So that we talked, if you missed it there, low magnesium level is associated with torsades de pointes there. So just going back to this, if you're like in your med surg class and you're, say, in the renal section, you'll definitely want to know about phosphorus a little bit more detail. If you're in the fluids and electrolytes, it's not likely, it's less common that it gets questioned about. But definitely know your foods that are high in phosphorus. So, your dairy, your meats, and your whole grains are those 3 food groups that are commonly questioned about. So you'll need to know that for especially your med surg class, less likely common for your fluid and electrolytes exam and your fundamentals of nursing class. So I'm going to go ahead and switch, since, we could go over it, but it's literally just me. We already went over hypo versus hypercalcemia. They're inversely related. So just know that. So by the way, guys, if you're watching, you can download, I'm going to go ahead and type it in here. You can download this guide I'm showing you for completely free on Coursera nursing.com. So if you go ahead, I'm going to put it in there, CorseraNursing.com, download this for completely free. If you go to the resources page, you'll find it. It's the Fluid and Electrolytes study guide. And also you'll find lots of other concepts such as EKG rhythm interpretation, completely free study guide. It goes over all of your EKG rhythms and teaches you how to actually identify them in the best way possible. And then cranial nerves is another one. We have lots of other study guides on there too for completely free. So if you go to that website, you'll find them. All right. So this is one of the worksheets. This is the worksheet I'm showing you right now. You actually can get for free. Okay, so let's go to IV fluids. So this is a very common concept that will be reflected on all of your nursing exams, really. So this really is truly like a foundation of understanding different questions that you'll get throughout the nursing program. So before we even talk about the different IV fluids, so we're going to talk about hypotonic, isotonic, and hypertonic IV fluids. Let's talk about the basics of fluids. We need to know about fluid spaces. So where does fluid even stay in our body? We need to understand that. So where does fluid stay? Well, fluid stays in intracellular space or the extracellular space. So intracellular literally means inside the cell. So fluid likes to stay inside the cell. That's one place it can stay. Now there's also extracellular fluid, which actually has two different types. There's an extracellular means it's outside of the cell, so it's not super complicated. So fluid only has so many choices to go. It can either be in the cell itself, or it can be outside of the cell, whether that's in the intravenous space. So that's actually the vascular space. So like your veins, not complicated. So of course, blood needs fluid to transport throughout the body. So that would be where it stays there. That's where most of our fluid stays, in intravenous space. And then also there's something called interstitial space. So it's the fluid surrounding the cell. Now, naturally, this is normal, but when that builds up, that's where we start calling, you may have heard somebody say third spacing. If a patient has peripheral edema, for example, well, it's called third spacing because there's space number 1 inside the cell, space number 2 out in the veins, and intravenous space. Well, if it builds up in that third space, which is your interstitial, it's the fluid directly surrounding the cell. So you guys can see here on this little chart here, interstitial, this is the fluid that's surrounding the cell because these are your cells. So it could be, there's your 3 spaces technically, really. Inside the cell, it could be around the cell, or it can be in your vascular space, okay? So not very favorable if it's a bunch of fluid building up in the interstitial space because that's where you see peripheral edema. So if you know those fluid spaces, you're going to then understand where the fluid likes to go. There's only so many places, right? Well, we talked about sodium earlier, about hypo versus hypernatremia. By the way, guys, this course, if you're just now joining in, this will be on our YouTube channel on Coursera Nursing. So if you guys can actually watch this entire course, and we already have a fluid and electrolytes course on the YouTube channel. So if you guys wanted to watch that too, but if you want to watch this live of us going over it, then you can on Coursera Nursing on the YouTube channel there. But just to go over, so sodium and water, we talked about hypo versus hypernatremia earlier. Well, if you guys remember, my favorite phrase to remember is that sodium sucks. So you guys see here, you got your fancy little sodium that's vacuuming up water. Well, it literally, water is so attracted to sodium that wherever sodium goes, water flows. There's another mnemonic for you guys. So osmosis is that exact thing. So you guys hear osmosis, diffusion. What in the heck are these confusing things? Well, osmosis, it is the movement of water. So you guys got to remember, osmosis is talking about water. It's the movement of water from a lower concentration to a higher concentration. What the heck does that even mean? When we talk about concentration, we talk about sodium levels. So think of it like a glass of salt by itself, right? There's nothing in the glass other than just salt. And then you just dump a bunch of water in it. Well, water likes to follow sodium wherever it goes. So when the cup was just sodium, right? It's super concentrated. There's lots of sodium in there. Well, when you dump a bunch of water in it, now there's not as much concentration of sodium because now it's getting diluted by the water. So the sodium is dispersed out throughout the water now instead of just combined in the bottom of the glass. So that's what concentration means. So if you guys remember sodium sucks, or wherever sodium goes, water flows, whatever you'd like to remember, is that water is super attracted to sodium. And what the whole function of osmosis is to make sure that the sodium doesn't get too concentrated or too low. So too unconcentrated. So it's water balance. So say if we have sodium, let's talk about our fluid spaces. So let's say we have hypernatremia, right? So what does hypernatremia mean? Well, it's above your 145. We can know the numeric, but let's actually understand it. We have a high amount of sodium in the vein, right? In the vascular space. So, okay, water, where does water stay? Well, it either stays in the cell, interstitial space, or in the vascular space. If we have a crap ton of sodium sitting in the vascular space, well, where do you think this water is going to go? Wherever water goes, or wherever sodium goes, water flows, right? Or sodium sucks. So sodium is going to suck water out wherever it's coming from, or wherever it's currently at. So water is going to leave the cell and go into the vascular space because it goes from a lower concentration to a higher concentration. So if the sodium levels were higher in the vascular space than they were inside the cell, then the water is going to leave the cell because I need to balance my water out because there's too much sodium in the vascular space, so I need to leave the cell to balance out the sodium here. So that's where you hear about osmosis, is water from a lower concentration to a higher concentration. Now, I know this can kind of get people down into a rabbit hole, so please put it in the comments if that didn't make any sense to you. I really want to make sure you guys understand that, because if you understand this, IV fluids are so easy. Like, if you understand osmosis, IV fluids are so easy. So don't try. If you really pay attention to this concept, you'll be very golden. Now, diffusion's not as important as understanding osmosis, but it is on your exams. Diffusion is the movement of a solute, so sodium, from a higher concentration to a lower concentration. So it's the movement of sodium. So if you think diffusion starts with a D, right? Diffusion starts with a D, and also so does downhill. Well, what is downhill? You go from a higher spot to a lower spot, right? So think of it, higher concentration to a lower concentration, because diffusion goes from higher to lower. All right, so but movement of a solute, aka sodium in this case, because all these IV fluids we're about to talk about is fluids that are full of sodium. That's the main component, because what does sodium do? It controls your water balance. Well, that's what we want to do when we give IV fluids. That's the main purpose of it, is to make sure we're controlling their water balance. So whatever's going on with the patient, we have an IV fluid for it to make sure they're adequately hydrated and that we have enough blood going around the body, circulation, of course, to transport whatever we need. So diffusion is not as important as to understand as osmosis is, because if you understand wherever sodium's high, if there's a high buildup of sodium somewhere in the body, whether it's the intravenous space, interstitial space, or inside the cell, the water is going to come follow it to make sure that it's not getting too high. So wherever sodium goes, water flows. So remember that. Drop in the comments there, guys, if you are having trouble understanding that. If osmosis is an issue for you, definitely take the time to understand it, because if you understand osmosis, these IV fluids are super easy. So let's actually first go over isotonic, because isotonic's your medium, right? So iso, it means stay, or if you think of it like an isometric exercise, right? It's like you remain still. So isotonic, I want you guys to remember this phrase, iso, still, in the vessel vil. So what does that even mean? Well, when you give an isotonic fluid, so it's not a fluid that's super high in sodium or a fluid that's super low in sodium, it's a medium balance of sodium. Well, if you introduce isotonic fluids into the vascular space, the water stays in that place, because it's not telling water to go, the sodium's not changing so high to the water leaves the cell or leaves the vascular space. The whole purpose of giving an isotonic fluid is to expand the vascular space. Hey guys, it's Wilker Patrick, nursing educator inside Corsetta. I wanted to let you guys know that I will help you with anything you need at any time if you just send me a text at 940-218-4062, 940-218-4062. Let's get back to the video. So that's why we give isotonic fluids to patients that are super hypovolemic, so low amount of volume in the blood, that are hypotensive, because when you introduce that, it's the safest way to rehydrate a patient, because you're not messing with the cell. So the cell does not get touched in isotonic fluid. It's just there to expand the vascular space. So it's a medium amount of balance of sodium. So all these fluids, once again, guys, are all just talking about sodium. So when you see like your 0.9% normal saline, or your 3% saline, your 5% saline, it's literally talking about the concentration of sodium. So don't overcomplicate it. So isotonic, if we look at all the other examples, it's the medium. It literally is the medium between hypotonic and hypertonic. It's 0.9% normal saline. And the lactated ringers is also considered isotonic. And then this is not very commonly questioned about, but you may or may not need to know it. D5W is at first introduced as an isotonic, but is most commonly referred to as a hypotonic fluid. So just know, guys, isotonic, iso still in the vessel vil, it does not touch the cell. It doesn't make it get bigger. It doesn't make it get smaller. Isotonic fluid is just there so that way fluid stays in the vascular space, because that's what we want a lot of the times, and it's the safest safest fluid that we can give without worrying about messing with the cell. All right, so other little side notes is that 0.9% saline is the only IV fluid that can be used with blood products. So that's pretty commonly questioned about thing on the NCLEX especially. And then lactating ringers should be typically avoided with renal failure patients. Why? Well, because it has a higher amount of potassium, not necessarily a absurd amount of potassium, but it has a higher amount of potassium than other options of IV fluids. So there's that too. All right. So let's move on to, let's do hypotonic and then we'll go up to hypertonic. All right, so we talked about isotonic where it doesn't touch the cell, right? Iso still in the vessel wall. The whole purpose is to just expand the water in the vascular space. The water's not traveling anywhere because the sodium's a medium balance. All right, so hypotonic. I want you to think hypo is similar to, it looks like the word hippo, right? So hypotonic, hypo equals swollen hippos. Okay, so what's swollen? Well, when we say swollen hippos, when we talk about any IV fluid, we're talking about what happens to the cell. So iso means same, like iso, same, still. Well, the cell is still the same. The cell's not changing. Well, with hypo, hypo is close to hippo. So think hippos are swollen and fat. So hypo, what happens to the cell? Well, it gets swollen and fat. So water enters the cell and the cell becomes swollen. Why? Well, remember osmosis, right? Osmosis is the movement of water from a lower concentration to a higher concentration. Well, we're giving IV fluids that have a low amount of sodium in them. So we introduce it into the vascular space, right? So we introduce low amounts of sodium in the vascular space. Okay, well, where's water going to go? Where's the sodium higher now? What fluid space out of those three fluid spaces has the highest amount of sodium concentration? Well, it's not the vascular space now. So the only other space that it can go to is inside the cell. So it's going to travel to the cell because that's where the higher amount of concentration of sodium is now. And it's going to swell up that cell. So hypo, close to hippo, swollen hippos, it's going to swell up that cell because the concentration of sodium in the cell now is more than the vascular space because we just introduced a sodium or a fluid that was low in sodium. Now, people get tripped up about this all the time, but please do not overcomplicate it. There is one exception to what I'm about to say, is that, of course, hypo means low, right? Well, the reason why we're saying hypotonic, well, it means it's low sodium. So if you look at all of these fluids right here, these are high numbers because it's hypertonic. These are isotonic because it's medium balance. Okay, this is your low sodium in the fluid. So 0.45% saline, your half NS, 0.33% saline, 0.225% saline. Those are low numbers. So it literally is that simple, is that hypotonic is just low sodium. So you're going to see low numbers because it is low sodium. The only exception to that is D5W. So that's 5% dextrose in water. So that is also the most commonly one used clinically for hypotonic fluids as a solution. So that is your low sodium IV fluids. Commonly used for hypotonic, so anybody with cellular dehydration. So why? Because, well, if we do want water to go into the cell, well, these are the conditions where we do want water to go in the cell, such as diabetic ketoacidosis, and then hypernatremia, because sodium levels are high in the vascular space. So we're going to dilute that sodium by introducing a low sodium fluid. Okay? Now moving on to hypertonic. So hypertonic IV fluids, think hyper children stay outside. So you guys remember, all of these relate to what it's doing to the cell, right? So iso still in the vessel wall. Iso means same, so it doesn't do anything to your cell. Hypo, so it's close to the word hippo. Hippos are swollen and fat. So what does it do to the cell? It makes it swollen and fat. Now we're going on to hypertonic. Hyper, so hyper children stay outside. So where does the fluid stay? It stays outside of the cell. So what happens when the cell doesn't have a whole lot of fluid? Well, it shrinks up. So there's a lot of sodium in the vascular space because the fluids we're giving them are super concentrated in sodium. Once again, let's refer back. If you understand osmosis, you're going to easily understand all these IV fluids, is that water goes from a lower concentration to a higher concentration. Well, where's the higher concentration of sodium now? It's in the vascular space because we're given an IV fluid that has high amounts of sodium. All right, so we give that high fluid or high sodium content in the vascular space. The water that is sitting in the cell is now like, oh, okay, the sodium's high in the vascular space. We need to leave the cell and go to the vascular space to balance that water and sodium levels out. So now the cell is left dehydrated technically, with low amounts of water, and it didn't reacts by shrinking. So don't overcomplicate it. Once again, your examples of hypertonic fluid, hyper means high, right? So when we say high, that means we're talking about sodium, because all of these fluids are components of sodium. 3% saline, it's a high number. 5% saline, high number. D10, 10, high number. D5, another high number. D5 half NS, another one. The only exception, once again, guys, is D5W is a hypertonic fluid, so you guys just need to remember that. But look, high numbers, because it's literally talking about the sodium contents. Medium, ISO, medium number. And then low numbers, because it's a low amount of sodium. So that's that. And then the common uses for this is hyponatremia. So we talked about hypo versus hypernatremia earlier. So make sure you guys really understand that hyponatremia, you're at risk for cerebral edema. So if you don't want to overcorrect it super fast, because we talked about that condition earlier, it can cause severe brain damage at that point if you correct it too fast. So you just want to know that you want to monitor the sodium levels frequently anytime you give a hypertonic IV fluid. So severe hypovolemia, this is not as common really realistically, but it is something they may question you about. And then once again, cerebral edema, and then metabolic alkalosis as well is another condition that could possibly be used for hypertonic fluids. All right, guys. There are also some other things that they may ask you about for specifically IVs. So knowing the difference between infiltration and phlebitis and all that good stuff. But that concludes our course with IV fluids and our course with electrolyte or fluid and electrolytes in general, and then also IV fluids. Is there any questions that you guys had throughout this course, whoever has been watching? Once again, guys, if you want to watch the full course, if you're just joining in, make sure you guys go to our YouTube channel. It is called Corsetta Nursing. And also this study guide I'm showing you right now is completely free on CorsettaNursing.com. So you guys will see it in there. Yes. So Mia, there is a place you can find this. So I put it in the chat there, and it's also in the bottom corner there, but it's called CorsettaNursing.com, and it's completely free. So if you literally go there and go to the resources page on CorsettaNursing.com, there's lots and lots of free study guides there, including this one that you're seeing right now, to help better understand it. And this is a worksheet too, so you can actually fill it out. I'm putting it in the chat right now for you, CorsettaNursing.com. And then also our YouTube channel, and that'll have this full course right here. And we've already done a fluid and electrolytes course, but this is, I like to do live so that way I can interact with, some nursing students live. But you'll see this on there. It's completely free. And we also have EKG interpretation. We have cranial nerves worksheet. There's ABG worksheet. Oh, good. That's cool. You just start. Are you a new grad nurse? And in the ICU, I started in the ED, and then I went into a neurotrauma ICU, and I did not think I'd like neuro, but I actually liked neuro, so that was pretty surprising. So yeah, if you're a new grad, congratulations. That's really awesome. Getting into the ICU, especially, you're gonna love it, especially if you really love detail. If you're a detailed-oriented person, it's super exciting, and of course, you get to see all the good stuff. If you're an adrenaline junkie. So that's a fun job, but congratulations, happy for you getting ICU. That was definitely by far my favorite. Okay, back soon for RN. Okay, so yeah, that's exciting. Yeah, thank you. I appreciate you guys staying on and giving it a watch and learning more with this. And like I said, this is fluid and electrolytes is of course introduced in your fundamentals of nursing class, but it's definitely a concept that you'll need to understand throughout the entire program, because they love, say for a cardiac exam in med-surg, they love to reflect on this concept all the time, because sodium, of course, controls lots and lots of different conditions, so it always gets called back on throughout your program. So super exciting. Thank you guys so much for watching, and Once again, if you guys want to give us a follow on you can follow us on TikTok here. We do full courses on here all the time that are not live, so you guys can get that. Or our YouTube channel has like the traditional like landscape view, so it's a little bit easier to see everything. But yeah, so if you guys want to follow us on YouTube, TikTok, you guys can find us there at Corsetta Nursing, and of course, this study guide is completely free on our website. We have lots of other ones too. But thank you guys so much. I will see you guys in the next video, hopefully. And have a good night. Have a good rest of your night, everybody. Hey guys, first of all, thank you so much for watching the video entirely through. It makes our day if we know that nursing school got a little bit easier after watching one of our videos. If you guys like this video, make sure you like it, subscribe to the channel for more, and drop down in the comments for any more ideas that you need help with nursing school. If you want to contact me personally, it's 940-218-4062. Thank you guys for watching, and we'll see you in the next video.